So good evening, ladies and gentlemen, again. Thank you again for being with us. This evening we're reporting to you that we diagnosed today 325 new cases of COVID-19, bringing our total to 3,235 cases. There have sadly been 17 deaths that I'm reporting to you this evening, 8 of which are in the east of the country, 3 in the south, 6 in the west, and 13 of them are male, 4 female. And the median age of these additional deaths is 84. And I'd like again to take the opportunity to express our condolences to the family and friends of each of these individuals. In respect of the deaths overall, we've now had 71 people who have lost their lives, 52 of whom are male, 19 of whom are female. 83% of them are over the age of 70. 2/3 of them are in the east of the country, which is in line with most of the other parameters of this disease. 54 we have reports of underlying health conditions, and 59 of them occurred in hospital environments. In terms of the more detailed breakdown to Sunday evening midnight, 2,677 cases, and there were 118 reported clusters involving 494 cases. The median age of those cases overall was 47, and approximately equal proportions of males and females. 703 people had been hospitalised out of that 2,677, 113 of whom had been admitted to intensive care, and we see the same transmission pattern that I've reported to you of about 50% community transmission. In terms of healthcare workers, a little more detail. We've had 1/4 of those transmissions occurring in healthcare workers, that number at 24% being 647. 61% of those are community transmissions, 14% of them are travel, and 26%, or approximately 1/4, are what we call nosocomial or hospital or healthcare related transmissions. So that's 1/4 of the 1/4 that we believe are healthcare related transmissions. In relation to the categories of those, 33% of them are allied healthcare workers, 31% of them are nurses, 25% of them are doctors, 9% are healthcare assistants, and just over 1% are porters. You'll be aware today that we held another meeting of the National Public Health Emergency Team. We discussed a number of things, as we do, on our agenda. We looked at, in particular, our contact tracing arrangements, and we have made and will communicate a recommendation to the contact tracing teams that in respect of taking contact tracing histories of cases, that the important contact periods to identify now is 48 hours prior to the onset of symptoms to cover the period of asymptomatic transmission. We have seen a further drop in the average number of contacts per case, such that it's now at around 3 contacts per case that's identified in contact tracing, which is a significant continuing improvement in the number of contacts identified for each individual case. We're also keen to make our contact tracing capacity available to allow us to contact trace some suspect cases in priority groups. I'll be working with our colleagues in general practice to communicate those arrangements in the next coming days. We've also, as I said, we would look more closely at nursing homes, where we've seen a number of outbreaks occurring mostly in the east of the country, to identify measures that will help us to strengthen the response in relation to those nursing homes, in particular to support staff and the centres in managing through these individual outbreaks that they will be experiencing, and to look at a range of measures that might help. And we'll be working with the HSE over the course of this week, and we meet again as a National Public Health Emergency Team on Friday to continue to, as I say, provide support and more direct guidance, training, equipment and so on to nursing homes right across the country, and in particular those that have experienced challenges in terms of outbreak management. And the purpose of that is twofold, as I've said to you before. Obviously, in the first instance, to protect the health and well-being of both the residents of those nursing homes and the staff working in those nursing homes, and also as a location in which transmission of infection is occurring. As I've said from the beginning, our focus in terms of our public measures was to try to interrupt and limit the transmission of this infection in community environments we've seen a significant range of measures implemented across society directed at that, and we have begun to focus now strengthening that continued response in terms of interruption of transmission in institutional settings where we believe transmission of the virus is occurring, and those specifically are nursing home and other residential settings and hospitals. So we're happy to take any questions that you may have. I might, if I may, first introduce Dr. de Gascoigne from the Virus Reference Laboratory to speak in a little bit more detail in relation to testing. Cillian.
Thanks. Good evening. So I suppose just to update on where we are. So the number of tests performed as of midnight last night across the country was 30,213. And I suppose of interest to us in light of the changed case definition last week, you might remember that the positivity rate up till last week was 6%. And the positivity rate of those samples that have been tested in the last week has increased to 15%. So that's really one of the things we were trying to achieve by changing the case definition to ensure we were testing the right people. And that's certainly early signs that we've managed to achieve that to an extent. I suppose one of the questions that is likely to come up in the coming minutes is around sort of turnaround times and how long people are waiting for tests, so I might as well get to that now. Certainly, people will be aware of significant constraints on testing at a global level from a supply chain perspective and significant laboratory reagents. So what we've been doing over the last week is prioritising hospitalised patients and healthcare workers and others in vulnerable groups. So unfortunately, there will be an awful lot of people in the community who will have been waiting maybe 7 to 10 days for a result. That was obviously unanticipated and is unfortunate, but it doesn't really change our plan of ramping up testing over the coming weeks to achieve between 10 and 15,000 tests per day. I suppose the message for those individuals is that the test is really being performed for a population benefit more so than the benefit to the individual. So they need to self-isolate if they're symptomatic for 14 days. And as I said, we will get a result to them. Everybody that's in the system will be tested.
Thank you, Cillian. Now we're happy to take any questions. Sorry.
Thanks. Zara King, Virgin Media News. Am I right in saying this is the largest number of deaths in one single day since the beginning of this in Ireland? And also, it seems like a substantial increase, say, on yesterday. Are we to believe that this might be the beginning of the surge that we were expecting?
So it is the largest number of deaths. We think overall it's in line with what we're seeing in terms of the growth of the epidemic. It's a little early to start to project and make any significant statements about the trajectory or the numbers of deaths. Each one of them obviously is an individual tragedy for families and for friends concerned, which is why we continue to express our condolences to them. In terms of the spread of the infection overall and questions around surge, we see the number of cases increasing. We see the rate of growth of the infection in around 15% or so. We dealt with this yesterday evening. That's a significant reduction from the early stages of this epidemic in this country, where the growth rate day on day was about 33%. So that's a significant impact of the measures and is moving us on the kind of, if you look at the curves, the flattening of the curve scenario that we've been describing since the beginning. We believe we are flattening the curve, but 15% growth is too much. We need to continue to work to try and flatten that growth further. But we do expect to see continued growth as long as we are seeing a trajectory that represents a positive increase. In other words, a percentage greater than zero in growth every day. That is an increasing epidemic. And we expect to see that continuing, and that's why we continue to emphasise the importance of all of the measures that are in place across society.
And a couple of your, I suppose, equivalents in other countries have warned or have said that they think that social distancing measures, maybe not such strong ones as we have at the moment, might be needed for many, many months or until a vaccine comes on board. What's your view on that?
So we've asked for a series of measures to be implemented at different stages. As you know, 3 major packages of measures, if I can describe them in those terms, to add to the initial measures that we have in place around contact tracing, case identification, public health management, and then the most important, which is around the personal behaviours that we have recommended since the get-go, before we ever had cases in this country, for the public to take up and to practice. And we've been very satisfied, if you like, with the response of the public. But we've had to institute measures of the kind that we now have in place. We see an impact of those. There's no question that if you look at the flattening of the curve scenario, the length of time that one experiences the infection passing through a population in a flattened curve situation is a good deal longer. What we would like to be in a situation to do is if we are able to see, let's say, positive control, suppression is the word that's being used, of the infection in this country, we may be able to relax or remove some of these measures, but we're not predicting this. But this is why we keep it under close review. If we find ourselves in a situation where some of these measures can be relaxed or reduced somewhat, what will become really important for us then is that we have strong continued public health messaging and public behaviour of the kind that we see, but really effective case detection, contact tracing arrangements and testing capacity to enable us to release those or relax those measures, such that if we do see an increase in cases arising, we'll be able to intervene on that as quickly and as early as possible. And that will be the strategy. I'm not going to make a prediction now as to whether that will happen or when it will happen. I've seen and I'm familiar with some of the what's been said internationally. Yeah. But that's our expectation at this point in time.
And could I also ask you, just in terms of the measures that we have adopted or introduced so far, is the aim to actually reduce the overall number of people who'll actually get coronavirus or get COVID-19, or is it to flatten the curve? In other words, do we still anticipate that a large number of people will get it, but just over a longer time period?
Our aim, first and foremost, is to protect as many people from picking up this infection in the first instance as possible. And we want to reduce that number as much as possible. The aim, if you like, of those measures is to try to limit that. I'm not going to say to you what the percentage of the population will be that will be impacted by those measures that we have in place. Will it be the same number of people spread over a period of time? We're not necessarily projecting that. We want to try and minimise the number of people who pick up this infection for as long as possible. The more people we can protect from this infection requiring intensive care, admission, or any such thing, the better. And that's our
So we're hoping to actually that the interventions will reduce the overall volume. Great. And then if I could just ask Dr. de Gascoigne a question just about the testing. How many tests are we running in the labs each day at the moment? And do we know what the false positive and the false negative rate is for tests? Or is there an estimate available?
Yeah, no, some very good questions. I suppose taking the first bit, first part of that first, I guess over the last week, we have seen a significant fall off in the number of tests provided because of the shortfall in global supplies. So we're probably in or around maybe 1,500 a day, I would think thereabouts across the country. Yeah. And then coming on to the accuracy of the test. So yeah, I suppose I've seen a lot of sort of talk about this, and I suppose it's trying to get an understanding for people as to what sort of the false positive, false negative rate. So the recommended sample type for COVID-19 would be samples from the upper respiratory tract and the lower respiratory tract. Obviously, from a convenience and acceptability perspective, we tend to sample the upper respiratory tract, but there are cases, and a small number of cases has been reported where people who may be negative in the upper respiratory tract, as in the virus is not detected in the upper respiratory tract, so by that I mean sort of the nose and the throat, but actually the virus will be present in the lower respiratory tract. So I'm not aware of any cases where the virus has been not detected in either the upper respiratory tract or the lower respiratory tract, and the person has been diagnosed with the disease. So I actually think the false negative rate is very low. The assay is very sensitive, but it depends, as I think it's important as to how we define it. So are there cases where the virus has not been detected in the upper respiratory tract and the person has been quite sick in hospital and the virus has subsequently been detected in the lower respiratory tract? Yes, we're aware of a handful of cases in Ireland that meet that definition, and it's not terribly surprising, but it seems that the virus has, I suppose, if you like, moved down to the lungs at that point and is no longer detectable. So that wouldn't really be a false negative in the sense of the assay. Okay. On the other side of it, from the false positive perspective, where we're generating a positive result in the absence of disease, I haven't seen any published data on it because obviously it's still quite new, but again, to my mind, it's certainly probably in our experience, it's certainly in the high 90s.
Okay, thank you.
You're welcome.
I have a couple of questions. First, one for you, Dr. Hoolan, and I'll move on to the others then. In relation to the NPHET meeting today, have you sent a letter to the Minister on the recommendations? And in relation to travel, did you come up with anything in particular on travel today?
So, honest answer in relation to the letter, because we were rushing down here to you, Fergal, and others, I have not yet finalised the letter and signed that, but that will happen as soon as I go back up to the office. The letter is finalised in terms of the measures that we will be recommending to the Minister, but I literally have not signed physically the final copy, so that's an honest answer to your question on that.
And then travel?
In relation to travel, we haven't identified any additional measures. We continue to discuss it. As I said I would yesterday evening, we'll discuss this each time we meet as the National Public Health Emergency Team. Again, we were reiterating and analysing the data. The footfall reduction that we have available to us in terms of travel onto the island from overseas, in particular through the airports, has been greatly reduced. And we will still see, as we'll continue to need to see, people coming onto the island from overseas for the purpose of bringing goods onto the island, people who are citizens of this country returning to this country, and from time to time we will need to have people who are not citizens of this country coming on to provide essential services. For example, I'm randomly picking an example like repair of essential medical equipment, where that might be an expert from outside of the jurisdiction who's not a resident. We need to have these people come into the country. So a complete prohibition would prevent those kinds of activities.
Dr. Killian de Gascon, can I ask you, just in relation to testing, you've given the figures on the number of tests to date, but what about the backlog? I mean, I've got a lot of messages from nurses and doctors and others in caring roles saying they could be waiting weeks to be tested. So is there a backlog figure you have, and how long will it take to clear that?
So I suppose there's a couple of parts to it, and maybe Colin will come into this as well, just from the sampling perspective. So I suppose there are people who have been given a referral to be sampled at one of the community sampling centres, and obviously people will be aware of the swab issue, where a number of those have sort of closed temporarily for a variety of reasons to allow swabs to come into the country. And then people who have been swabbed then, and the sample has come to the lab, there's a delay there at that stage, and that sort of comes back to the point I was making earlier, where we're aware, I suppose we've spoken with many of our suppliers, and their demand has increased by about 1,000% according to one of them. So they're ramping up production, but there's a significant delay in that coming. So the amount of testing that we're doing has reduced significantly over the last week. So I don't have an exact number for you, but certainly there are people who will have been sampled and their sample is in the lab, but they're waiting 7 to 10 days.
And Dr.
Just
Colin
to
Henry.
answer that, Fergal, because this came up last night, the testing centres have reopened, and our rate of testing now can easily accommodate the demands being referred through since the revised case definition came through last week. To build on what Killian's saying, the problems with the reagent, that's an international problem. We've read today from the UK and Germany, where they're facing great shortages of reagents, so it's not unique to us. But we're building our lab capacity. We've added on to our hospital labs, we said before. The Department of Agriculture, Cherry Orchard and Enfer coming on board, and as Killian said, we're working with the providers we have now to increase allocation, and we're also actively engaged with negotiation with other manufacturers through the IDA third level biopharma, and we're hopeful to increase capacity in the short term to address that turnaround time. So there is action, there are negotiations, and we're hopeful.
Two more things. There are
Can I just
reports.
add to that, Fergal, that again, and I know you're probably tired of me saying this, that for people who are waiting for a test for longer than they would like, for longer than we would like, the important public health measure for people with symptoms is to isolate themselves for 14 days as if they have the disease, and for the people they live with. And bear in mind the figure I gave you earlier on, we've now reduced the number of contacts per case to 3. In effect, for the most part, we think household contacts. So the important people in terms of the risk of transmission of this disease for you now are the people that you live with. And the isolation of both the case for 14 days and the restriction of movement of the contacts is really important in preventing that transmission from getting outside households. And we think that's the important public health measure. That's the thing that we want to focus on.
I have two more questions. One is, there are reports that some flights to and from China with personal protective equipment have been cancelled. Is that true? Do some reports of paperwork issues? No?
No, not that I've heard of.
And then just finally, that's fine, there was a tweet by a doctor that alleging that thousands of swabs taken that were awaiting testing were discarded due to the backlog and scarcity of testing kits. Is that true or false?
Like many stories, Fergal, that come out, absolutely false.
Thank you.
Evening, guys. Just to kind of follow up on what Fergal said, another tweet that's doing the rounds implies that 4 nurses are among the people who have died from the coronavirus since the outbreak. Can we get a bit of clarification on that? I know last week we said in the numbers on Friday night there was a healthcare worker. The HSE today said that none of their nurses had died. There seems to be a bit of confusion on this. Can we get a bit of clarity on that?
So we haven't given that information, and I've said, I think, on a number of occasions in the past, the place to go for trusted information in relation to this is not social media, it's not Twitter or tweets. We can't stand over the veracity of any of those. We're not going to get into the business of confirming or denying stories that appear that we haven't either seen or had time to examine. We've given out the data that we've given out. That's the data we intend to make available, and all the information that people need is available through the website of the HSE. That's the trusted source of information in relation to that. So we're not confirming that that's true, that story.
In terms of the kind of wider landscape, then, in what we've seen, and my colleagues in the media, I'm sure, will have had the same experience. In the absence of information, and when we have nothing to kind of countervail those assertions with, those things grow legs. In terms of the number of healthcare workers who have contracted this, people are kind of putting two and two together. What would you say to that?
Could I just add to what Tony has said, is that since the beginning there's been a great deal of stories, a great majority of which have been untrue, but more, I want to emphasise how hurtful these are to families and to people and friends of people who are ill and unwell. Rather than go into details, I think we all have heard stories over the past few weeks which have been completely untrue, but as I said, have been very distressing to people. And it's easy for people to put these stories on Twitter without any consideration for the impact it might have on the families or friends of people who are ill.
Thank you.
Hi, Shane Beattie from News Talk. Dr. Henry, if I could just ask you, you said there about the issue to do with testing, that there was a problem with the reagents, with the global shortage there. The Chemical Industries Association in the UK is saying that there's no problem with reagents, and they say that if they had been asked, they would be able to produce more. So can you just clarify, because they're saying this is in response to Michael Gove, excuse me, in the UK. They're saying there's no issue.
Well, I don't know of this organisation. All I can say is that it is our experience and the experience of right across countries that are experiencing epidemics in COVID-19, that there's a shortage of reagent, and securing enough reagent to carry out the testing is not just our problem, it's a problem right across the world, including the UK.
Shane, just to add to that, I suppose there are a couple of different components that we're talking about. So one that has been mentioned is lysis buffer. That's a sort of an initial step to inactivate the virus. That can be made by pretty much anyone. So we've engaged with colleagues in sort of academia in Ireland to address that issue. So that's no longer the immediate pinch point for us, if you like. The second issue is extraction material to actually extract the viral RNA, and that is proprietary, unfortunately. Now, there may be, excuse me, if we had a number of months, it might be possible to develop an alternative extraction method, but at this point in time, there's a certain amount of proprietary material that we need in the NVRL and the hospitals need to enable us to carry out the work on our existing platforms.
Just one question about face masks. On the one hand, among healthcare workers and in the wider population as well, I'm aware of the revised or adjusted or updated guidance from Martin Cormack and restating the guidance on face masks, but there does seem to be a growing sentiment among medics favouring more widespread wearing of masks in healthcare settings, often routine engagements with patients. And then just on the wider thing, internationally, you hear some governments saying that they're threatening to introduce obligatory face mask wearing among the population, and just what your view on that is, please.
I might ask Killian, who chairs the expert advisory group, to offer a view, because I know that has been a subject which has been the subject of discussion at that group, and maybe Dr. Henry might also have a view. Killian?
Thanks, Tony. So this question has come to us. The question really revolves around the evidence for the efficacy. So we do know that masks obviously have a benefit in the case of somebody who is symptomatic, as a means of preventing them or reducing the risk of them transmitting the virus onwards. And we also know that masks have a very significant role to play in protecting healthcare workers when they're caring for individuals who are infected, whether that be in the process of aerosol generating procedures or standard care. So there is no recommendation from the WHO or ECDC that I'm aware of to recommend the wearing of masks for asymptomatic individuals. We have kept this under review. We are obviously aware that of anxiety amongst healthcare workers and a variety of other measures, but from the point of view of the evidence that is there really isn't any to recommend the wearing of face masks for asymptomatic individuals, and they are very important part of our PPE, so we really want to preserve them for situations where there's evidence to support their use. But I'll maybe hand over to Colin then to talk about the other aspects.
Little to add to that, Paul, except we are talking to the colleges, to the clinical directors and clinical leaders, and indeed the representative organisations, and updating them and reviewing evidence as it comes through with Killian. But to add to what Martin Cormacan's, I've not little to add except to say that he's of the opinion, based on the best evidence to date, that the use of masks in asymptomatic settings adds little benefit, and indeed may confer some risks because of the increased movement or use of hands towards face in wearing masks in such settings. But as with anything else, we have to continuously review the evidence and experience of other countries coming through. So we're, as I said, in constant dialogue with the colleges and representative groups, listening to their concerns and reviewing our evidence.
Thank you.